Good evening, everybody. I'll be speaking on evaluation of the aorta by transesophageal echo. Actually, aorta assessment of the aorta by transesophageal echo is one of the important steps, especially in preventing the post-operative stroke in after cardiac surgery, wherein it occurs in about 1 to 6% individuals because of elderly individuals having atherosclerosis of the ascending aorta and the aortic arch is very common. Okay. Now, before I move on, I would like to have a little bit of anatomy of the thoracic aorta, where the diameter of the aorta is between 3 centimeters to 3.5 centimeters, with an ascending aortic length of 7 to 11 centimeters, and it courses from the fourth thoracic vertebra to the 11th uh, vertebral body. Okay. Now, these are some of the important views to assess the ascending aorta, arch of the aorta, and the descending aorta. Mid-esophageal aortic valve long axis view, mid-esophageal ascending aortic short and long axis view, descending aortic views, and the upper esophageal views. This is the mid-esophageal aortic valve long axis view, wherein the proximal and the mid-ascending aorta is visualized. The distal ascending aorta and the proximal aortic arch is not visualized because they overlie the trachea because of the presence of air in the trachea. These are termed to be the blind spots of transesophageal echo. Important here is to assess the aortic root dimensions, that is the aortic annulus, the sinuses, sinotubular junction, and the descending aortic, ascending aortic diameters. And we have to know the normal values of this to know whether these are aneurysmal or not. Now, this is the mid-esophageal ascending aortic short axis views and the long axis view, wherein we can see on the left this ascending aortic short axis view, or on the right side the long axis view, wherein the diameter of the ascending aorta can be measured very conveniently in this view to know whether it is aneurysmal or not. This is the descending aortic short and long axis view. This view is important, especially to know the presence of intimal thickening in these in the aorta, whatever level it is, whether it be the ascending aorta or the descending aorta, or is there any presence of any aortic plaques or any dissection flaps are seen or not, or even to assess the presence of any pleural effusion in these patients, especially in type B dissections. This is upper esophageal aortic arch short and long axis view. Here we can know the involvement of the arch vessels, especially in dissections, whether the left common carotid or the subclavian or the brachiocephalic artery vessels are involved, the intimal flap is involved in them or not, and we can, by visualizing these views, we can help the surgeon in planning the surgical procedures. Now, coming to the aortic diseases, I will be speaking with aortic atherosclerosis. Now, actually, Royce et al. Have divided the thoracic aorta into some 6 zones. The proximal ascending aorta is zone 1, mid is zone 2, and distal ascending aorta and the proximal aortic arch is the blind spots, like I already told you, because of poor visibility, because they overlie the trachea. And the distal aortic arch and the proximal descending aorta are the zone 5 and 6. Important is to know the zones is, if you have a grade 5 plaque in zone 5 and 6, mean if you have, then it becomes mandatory for us to assess the zone 3 and 4 to prevent any postoperative strokes. Now, how do we assess the zone 3 and 4 is by transvaal echo. It is not possible because they are the blind spots. Best is to move over to epi-aortic imaging. By that, we will be able to know whether the atheromas are present in zone 3 and 4 or not. Now, these are the grading of the aortic atheromas. If you see, the incidence of stroke is about 46.5% in the presence of a mobile atheroma. And if the atheroma is about less than 5 millimeters, it is about 5%. Now, this is the grading of the aortic atheromas. Now, transvaal echo should be used to identify and grade the atheromas, and also it helps us in altering the surgical procedures, either by adopting femoral arterial cannulation, altering the site of aortic cross clamping, or changing the site of graft anastomosis, or entirely avoiding anterior cardioplegia and resorting to retrograde cardioplegia. Now, this is another view. On the left side, you can see the epi-aortic imaging, the ascending aorta, with this grade 3 plaque. And the right side, you can see in the mid-esophageal ascending aortic valve long axis, you can see the grade 5 atheromas be oscillating in this. By this, we can change the surgical patterns depending on the surgeon's convenience. Now, this is Descending aortic views, wherein you see the grade 5 edema, a mobile plaque, where the incidence of stroke can be about 45 to 50%. And on the right side, you see in the aortic arch the grade 4 plaque. Now, coming to aortic aneurysms. When do you say the aneurysm is aorta is aneurysmal? Any dilatation of more than 50% of the normal diameter is termed to be aneurysmal. Now, it is termed to be dilated, which varies between 3.7 to 5 centimeters. And of course, it is aneurysmal if it is more than 5 centimeters. And we call it as dissected if there is a presence of an intimal flap. Now, these aortic aneurysms are divided into three groups depending on the location. It can be ascending aortic arch, or descending thoracic aneurysms, or thoracoabdominal aneurysms. Okay. The aneurysms can be either vesicular or fusiform. Fusiform in the sense they have an uniform shape with symmetrical dilatation. Saccular aneurysms are localized outportion of the aortic valves. And the reasons for these aneurysms, it can be degenerative, it can be atherosclerotic, Marfan's, Ehlers-Danlos syndrome. Trauma is, of course, very common, one of the common entities, or it can be because of uncontrolled hypertension. These are the causes for aneurysmal dilatations. Now, this is the view of the aneurysmal aorta. If you can see, we are not able to define the aortic sinuses, the sinotubular junction, or the origin of the ascending aorta. In this, that is, this is termed as effacement of the aorta, and also you can see on the left side that the aortic annulus is dilated. This invariably tends to cause a severe aortic regurgitation. So we can measure the aortic root dimension in this, and this is an ideal patient for doing a Bentaz procedure. Now here, this is a mid-esophageal RV inflow overview, where you can see the right coronary cusp is prolapsed and it is highly aneurysmal. You can see stasis of blood in the aneurysmal sac. You can make out the spontaneous echo contrast. That is, virtually the aneurysm is protruding into the RVOT and causing obstruction to the flow in the RVOT. These are the various types of aneurysms, wherein you can see a dilated aneurysm on the right upper side. You can make it the aneurysm is dilated to about 8.7 centimeters. Now coming to the thoracoabdominal aneurysms. As per the Crawford classification, we have four types, type 1 to type 4. The type 1 is involving above the renal vessels. Okay. Type 2 is involving below the left subclavian artery down to the bifurcation of the iliacs. And type 4 will be below the diaphragm. The aneurysms are involved below the diaphragm to the bifurcation of the iliac vessels. Now, what are the surgical indications? We know that aneurysms with a diameter twice that of normal aorta is a surgical indication, with the sinuses being more than 4 centimeters. Okay, or if it is an ascending aortic aneurysm with then more than 5 centimeters with the aortopathy, or more than 6 centimeters without aortopathy. Especially patients with connective tissue disorders, strong family history of aortic aneurysms, they are all subjected for early operative therapy because of increased risk of dissection or rupture. Now, we can use the transvascular echo to define the size and location and extent of the aneurysms, whether the hematoma is present or not, or helps us to identify the associated aortic valve diseases. Especially, it helps the surgeon in pre-planning the surgical procedures. Coming to dissections. Now, the Stanford classification of dissection is Stanford type A and type B. Type A is involving from the ascending aorta down to the bifurcation of the iliacs, and type B is below the left subclavian artery, below the left subclavian artery. That is the descending aortic level. Now, important thing for a dissection is the presence of an intimal tear, and we have to have a true lumen and false lumen. Especially the true lumen and the false lumen, may extend into the branches of the aorta, causing malformation of the organs, can cause ischemia or even occlusion. And sometimes, because proximally they may extend and leading to a severe AR. And also, they involve the coronary, leading to some ischemic episodes also. And most common, important is the mortality rate is going at the rate of 1 to 3% per hour during the first 48 hours. Now, MRI and T is one of the ideal indications to diagnose a dissection. But if you look at the sensitivity and specificity, be it the MRI, CT scan, or the TE, the sensitivity and specificity is the same. It is about 98%. So in unstable patients, transvagal echo would be ideal to do a TE, which hardly takes us any time. Do in 5 minutes, you can assess the patient and take him into the operating room for better outcomes. Okay. If you look at surgery is recommended for type A dissections and medical management for type B dissections, but the mortality rate for medical and surgical managements are similar for type B dissections. What are the features of dissection? The presence of an intimal flap with a true lumen and a false lumen, and there is a complete thrombosis of the false lumen if it is long-standing dissection, and there is always a forward systolic for the true lumen. Now, locating the intimal tear site is very important because resection of the primary site decreases the incidence of complications and reduce surgeries. Usually, the intimal tear arises in the ascending aorta 1 to 3 centimeters above the right or the left sinus valsalva in about 70% of the individuals, and at the site of ligamentum arteriosum distally in about 30% of the individuals. Okay, this is one of the views showing the descending aortic view showing the true lumen. It always expands in systole, and if you place an M mode across there, you can know the systolic expansion of the true lumen because the true lumen uh, 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 expands towards the false lumen, and sec is always invariably present in the false lumen. This is the 3D view showing the dissection flap. And this is a type A dissection where there is a circumferential dissection flap which prolapses into the aortic valve, which opens in diastole and causing a severe MR. You can see the flap moving in and out of the LVOT. Okay. And also we need to assess for the coronary involvement because 10 to 20% of the individuals coronary arteries are involved. And dissection involving the aortic arch, you can make out the intimal flaps here. And also involving the arch vessels, the brachiocephalic artery on the left and the left coronary artery on the right side. Okay. Now, descending aortic long axis view, here you can see the intimal flap moving in and out. If you put an M mode across this, you will see the forward systolic flow pattern. The arrow, the green arrows indicate the presence of a true lumen, and towards which side the flap moves is the false lumen. By this, we can make out the true lumen, false lumen. The type B dissection showing the descending aortic view. You can see, in fact, left side pleural effusion can be seen in these patients. Okay, if you see in type B dissection, pleural effusion is very common. In type A dissections, pericardial effusion is very common. Now, complications, if you look at in general, aortic insufficiency is occurring about 70% of the individuals. Coronary dissection, 10 to 20% of the patients. Pleural and pericardial effusion is also common, and global LV dysfunction, if the coronary involvement is seen, is known to occur. Okay. Now, important thing is we need to differentiate between an artifact and a true intimal flap. Artifacts have got indistinct borders. There will be no rapid oscillatory movements. On the top, you can see actually rapid oscillatory movements. Down below, you can see there is an artifact. You can see the extension of the artifact through the aortic wall of the straight line. And if you put a color flow across this artifact, there will be presence of color flow on both sides of the artifact. Now, intramural hematomas. There is thickening of the aortic valves. It can be in the ascending aorta or the descending aorta, but there will be no intimal flap. It is probably because of the rupture of the vasa vasorum. Okay. Descending aortic ones are managed always medically, just like dissections. Now, giant penetrating ulcers, these are very commonly, especially in elderly individuals with hypertension, hyperlipidemia. There is progressive penetration, which may result in intramural hematoma, aneurysm, and later on onto a dissection. You can see the yellow arrow pointing towards the aortic penetrating ulcer. And deceleration injuries are very common, especially at the ligamentum arteriosum, just distal to the left subclavian artery. These are because of whiplash injuries. It's very, very common. Usually, the mortality rate is very high in these individuals. Actually, this is the image of one of my friend's uncle who was texting while driving, texting on his mobile while driving on a Kuala Lumpur highway. You can see the transection of the spinal cord. Okay. Now, wrapping up this topic, T is an invaluable imaging model actually in the management of aortic pathologies, and it has to a very large extent, improved the patient outcomes. Thank you very much.